Good morning, everyone. My name is Eve Osman, and on behalf of the University of Michigan Injury Prevention Center and our colleagues at MDHHS, I want to welcome you to the first in a series of discussions related to the opioid epidemic. Today, we will focus on safe prescribing and the 2022 CDC guidelines. We have about 90 minutes and we have built in time for Q&A, so please do ask questions. If you don't mind typing them into the chat, we will be collecting them and then answering them at the end of the presentation. We hope that this is going to be an excellent conversation. We're all colleagues and we've agreed to be informal, so we are going to be using first names. So we do not have any disclosures to share with you. I have two fantastic panelists who are going to be joining us today. The first is Jillian. She's a pain management clinical pharmacist at the University of Michigan. She also coordinates the pain and palliative care residency program at U of M. Eliza is an assistant professor in the Department of Family Medicine at the University of Michigan. She is also the medical director of addiction services at Packard Health, and I am faculty in the Department of Emergency Medicine. Sorry about that. So for today's agenda, we are going to be covering a lot of ground. I do want to mention that in order to receive CME credits for the live event, you're going to need to complete the evaluation after this session. It will be emailed to you by our team, and you can claim up to 1.5 Category 1 credits. I'm going to share with you data that all of you are aware. For the past few years, overdoses have continued to claim more and more lives, approximately 100,000 people per year. In Michigan, this equates to approximately 8 people dying of overdose each day, and many more experiencing non-fatal overdose. As many of you are aware, the rise in synthetic opioids over the past decade or so are fueling the dramatic increase in overdoses over the past few years. And in Michigan, we are finding that individuals think they're using heroin or they think they are using cocaine or other stimulants, and in actuality, they are exposed to fentanyl. And this too is causing great problems and an increase in overdoses. I'm so sorry, my mouse is super sensitive. The origins of the epidemic are multifactorial. Many of you who have been in practice for a long time will remember that in the 1990s, pain became a vital sign, and there was a big campaign to encourage providers to focus on pain as an important component of managing their patients. And while this isn't wrong, there were some unintended consequences. In the early 2000s, there was a push for new pain management standards, and this made not prescribing opioids for pain an inhumane thing. If you weren't addressing pain in an aggressive manner, you weren't a good doctor, you weren't a good clinician. And a lot of this push came from pharmaceutical companies as we have become more and more aware in recent years. We are now faced with a situation where the opioid epidemic is largely iatrogenic. We played a big part in this as providers. However, today we can make a difference and we can curb that current trajectory. We can make important decisions around safe and appropriate prescribing of opioids. We can provide education to our patients and our communities, as well as policymakers. We can help those who have opiate use disorder to find treatment, and we can prescribe medications for opiate use disorders as primary care providers, as emergency physicians, as non-addiction medicine trained individuals in the healthcare space. And last but not least, we can provide our patients with naloxone, whether they have opiate use disorder or they're at risk for overdose, and we can educate in general terms around harm reduction. I am so sorry. Again, my mouse is super sensitive. There's a lot of work to do, and there are a lot of areas of work that need to be done. Today, we're going to be focusing just on one aspect, and that is prescribing practices. In future seminars, we're going to be talking about stigma, we're going to be talking about harm reduction, we're going to be talking about equity and how to collaborate with patients and communities around um, um, reducing overdose deaths and providing care for patients with opiate use disorder. Lots and lots of literature out there on how to safely prescribe opioids. We are collating all of these resources, and we will be sharing them in a Google Doc with all attendees. And without further ado, I would like to move and share the slides with Eliza, who is going to be discussing the changes from 2026 to 2022, and she's going to start to describe the new recommendations regarding the decision to initiate opioid therapy.
Great, thank you so much, Eve. So some folks may remember a little bit about the 2016 guidelines, and I'm just going to first outline a little bit more about what's particularly different in this 2022 set of guidelines before we move into actually going through each recommendation. So one key difference is really that there's a broader clinical audience intended with these new guidelines. The 2016 guidelines really focused more on primary care clinicians. However, now we're really focused on all prescribing clinicians in the outpatient setting in particular. So family physicians, nurse practitioners, physicians assistants, and internists, certainly in the primary care realm, but also outpatient clinicians such as dental clinicians, emergency surgeons, occupational medicine, neurologists, and OB-GYNs. So really expanding the audience for this, recognizing that we really all share a responsibility and also really have this opportunity to help improve our prescribing practices and decrease overdose deaths in the long run, while also appropriately treating pain. So this set of guidelines was really founded in 5 basic principles that were initially devised before the guidelines were written. And so I'm going to just kind of walk through those with us. So first of all, this first principle really speaks to broadening our conversation about pain management in general, so that we're appropriately assessing and treating pain, really regardless of whether we determine that opioids are going to be part of the treatment regimen. So really sort of an all-encompassing assessment about pain. The second principle emphasizes really the way in which these recommendations should be applied, which is not a set of rigid rules or algorithms, but really a set of suggestions that can be taken into consideration and then tailored to each individual situation, really allowing some flexibility based on clinical judgment and based on that specific patient situation. The third principle is really focusing on a multimodal approach to pain. And we all certainly by now have talked a lot about the biopsychosocial approach to understanding pain and then to treating it. So really emphasizing that, of course, because of this, we really need to engage a multidisciplinary team as we are treating folks' pain. The fourth principle really focuses on kind of speaking to the critiques of the 2016 guidelines, which were concerning clinicians' use of those recommendations, maybe more as sort of rigid clinical guidance, which ultimately led to more of a widespread rapid opioid tapers and some related policies that with unintended consequences really did cause some harm to folks. So the hope really is that these new recommendations and guidelines are understood as suggestions, again, to be interpreted in a clinical context using your judgment and not applied so broadly or rigidly as the 2016 ones were. And finally, the fifth principle highlights the need for consistent attention to inequities, such that we're really providing appropriate pain management to all patients. It really emphasizes appropriate communication and equitable access to all pain management modalities. And we'll talk a bit more about that. But obviously that last piece is sort of beyond the control of the individual clinician, right? The access to various forms of pain management, but can really speak to policymakers as well. So this is a little bit of just a summary slide of the guidelines that Jillian and I will be reviewing with you next. And then the image on the right comes from the Department of Health and Human Services Pain Management Best Practices, which is a very robust, probably 300-page document, but really comprehensive and can kind of complement these 12 CDC recommendations that we're going to go over with you. And it highlights specifically how to provide patient-centered care in the domain of pain management, how to optimize patient functional outcomes, more details on the appropriate use of various pain medications, the importance of addressing and reducing stigma, and reducing risk through a very comprehensive risk-benefit assessment. And it really emphasizes the importance of education in all domains across providers, patients, public, and policymakers as well. So it's just outlining a much more detailed and comprehensive approach. And that is linked there on the slide. So now to dive into the guidelines and recommendations themselves. So these new guidelines, again, include 12 specific recommendations that we'll go over. And this is focused on patients who are 18 years and older, and specifically divided up into folks who have acute pain, subacute pain, or chronic pain. And this doesn't include these several different populations that are also listed here. So first set is going to be focusing on whether or not to initiate opioids for pain at all. So recommendation number 1 really addresses the management of acute pain, and particularly it reminds us to optimize the use of non-opioid pharmacotherapy first, and also non-pharmacotherapy options before resorting to opioid therapy. It also refers to robust data that non-opioid therapies are at least as effective as opioids for many, many types of pain, types of acute pain that opioids have traditionally been used for. And finally, it emphasizes that if you are choosing to start an opioid, perhaps given non-response to other therapies or the severity of the pain, it's really important to clearly discuss the very realistic benefits and the risks of opioid therapy with patients. This is just a diagram that, again, sort of summarizes the pharmacologic and non-pharmacologic interventions for acute pain. With all of these, to be optimized really before considering moving on to opioids. I think most of us know, but worth restating, of course, that unfortunately many of the non-pharmacological options are not covered by insurance and are often cost prohibitive for many of our patients. So in our clinical settings, we certainly have to be realistic about our recommendations for patients. And be really cognizant of the inequities in pain management that can stem from the inaccessibility of some of these therapies. However, this can also hopefully be, a call to action for policymakers, for insurance, for better coverage of those non-pharmacologic therapies and interventions. This image is coming from the Michigan Safer Prescribing Toolkit, which will be linked, and it really just depicts, again, sort of an analgesic ladder, demonstrating sort of at which pain severity you might consider which types of medications. And, as Eve mentioned earlier, we certainly have come to realize that kind of the 1 out of 10 pain scale certainly is fraught and complicated. And this does sort of refer to that scale. But this can be a helpful way of just sort of imagining at what point you might consider different types of therapies and sort of at what thresholds you might decide to move on to opioid therapy. A second recommendation is focused on, again, kind of switching from acute pain over to the subacute and chronic pain categories. And again, the 2016 guidelines really didn't focus on the acute and subacute elements of pain. So this is saying, really same as for acute pain, non-opioid therapies are preferred for both subacute and chronic pain, and really only to consider opioids after a clear risk-benefit assessment. If you do decide to start opioids, of course, re-emphasizing that we should always be discussing the realistic benefits versus risks with our patients in a very candid fashion. There should also be a really careful shared discussion with the patient around their pain and their functional goals. And this is really, again, that, getting pain to zero probably isn't going to be a realistic goal for most folks, and really, shifting the conversation toward functionality and meeting patients' goals in life, separate from just what their actual pain number is. And as a clinician, it's also really important to consider really upfront how and under what conditions that opioid therapy would be discontinued or tapered if at some point the risks really begin to outweigh the benefits. And this image to the right just lays out some steps you might consider prior to initiating opioid therapy. This comes from an excellent podcast that's linked here. So again, kind of talking about very first, of course, is having a conversation with a patient, learning more about their pain, setting some realistic goals, and talking about all the multimodal forms of therapy that we can use to address their pain. And then next is kind of discussing things like physical therapy, hot and cold packs, topical things that patients may not think will be effective, but really can help in many forms of pain. And then after that, sort of turning to the non-opioid pharmacotherapy, so NSAIDs, Tylenol, treating if someone has neuropathic pain, using other agents such as gabapentin, pregabalin. And then finally, using opioids mindfully if you do decide to get to that point. So starting with the lowest dose, and we're going to talk a lot more about that in the next set of recommendations. And finally, this is a little bit more of a pictorial, just re-emphasizing kind of what factors you might consider in your risk assessment. So again, doing a detailed patient history and continuing to gather that history really over time. Doing your physical examination and then gathering additional data such as using toxicology testing, reviewing the PDMP, and we'll dive into those details a bit more on later slides. And then really kind of coming out with your risk assessment of that patient. Are they low risk, medium risk, or high risk if they were to be prescribed opioid therapy? And then next, I'm going to pass to Jillian, who's going to take us through the next section of recommendations around selecting opioids and determining dosages if you do decide that opioid therapy is appropriate. Jillian?
Great. Thank you, Eliza. All right, let's jump into opioid selection and then based on the opioid you select, dosages. Recommendation number 3 is when starting opioid therapy for acute, subacute, or chronic pain, clinicians should prescribe immediate release opioids instead of extended release and long-acting opioids. This is not significantly different from the previous recommendations in terms of starting an immediate release before you move into an extended release, but it's important to reemphasize here. Immediate release opioids are faster acting. They have a faster onset of action. They last a shorter amount of time. Typically for our immediate release opioids, and I'll go over this in a little bit as well, they last about 3 to 4 hours. Hydromorphone lasts typically for someone who is healthy in terms of no compromised kidney function. Hydromorphone lasts on the 3-hour mark, and morphine and oxycodone tend to last more towards the 4-hour mark for a short-acting opioid. And our extended release opioids and long-acting opioids, so these are opioids that have been manufactured to release over a period of time. And the mechanism in which they do that release is different for each product and formulation. And the only really truly innately long-acting opioid out there is methadone. There's no specific way that this is formulated to release slowly. It is innately long-acting, which makes it one of the most unique long-acting opioid medications. And I also want to throw in here, we have examples of long-acting, so this methadone, transdermal fentanyl, our extended release hydromorphone, hydrocodone, which is fairly unusual. I don't think I've ever seen long-acting hydrocodone in morphine, but also buprenorphine is a long-acting opioid. It's a partial agonist, but it is a long-acting opioid. And the other one that I want to point out for our immediate release opioids, which I am highlighting here because I see this often in practice, and I think it's important to point out and use this opportunity to kind of give you a clinical pearl about tramadol. And so I think there's this misconception that tramadol is a lower potent opioid and a safer opioid because of that, which is not the case. So tramadol acts on the mu opioid receptor, similarly to our other opioids, and it also has an active metabolite. So it's metabolized by a couple of different cytochromes, 3A4 and 2D6. And because it's metabolized by 2D6 into this active metabolite, it does work on the mu opioid receptor, but it also has activity as a serotonin and norepinephrine reuptake inhibitor. So unlike our other opioids, it also impacts our neurotransmitters, which can really complicate things for patients who are already on a lot of different medications. And in addition, because it's metabolized by CYP2D6, there's huge genetic variation throughout the population in how our cytochrome 2D6 works. And if you're an ultra rapid metabolizer of CYP2D6, then you can be at risk for respiratory depression and increased adverse effects of tramadol. So a lot of people, right, are not getting pharmacogenetic testing in their patients. It's not always covered by insurance, and we don't have that information. And so I'm using this opportunity to just provide a nugget. Tramadol is an immediate release opioid, but that doesn't make it safer. And actually, there's a lot of genetic variation and side effects because of how it works with serotonin and norepinephrine. That's my little tramadol nugget for you. Okay, let's keep moving on into the opioids themselves. So there are great resources out there. The Michigan Safer Opioid Prescribing Toolkit is one of them. This will be linked for you in the resources after the presentation. There's multiple publications on how to manage acute pain with an opioid medication when that becomes appropriate. And this table here, this comes from one of the badge resources that we have at our own institution, but it's not, it is similar to other equianalgesic opioid tables that have been published and at our institutions across the state. So if you have not seen this before, let me orient you a little bit to this table. This is a table that lists each opioid, the formulation, and the equianalgesic dose. I'll explain that a little bit more in just a second. The onset and duration of action. And so everyone each patient is going to have a different experience with an opioid. And some patients just have a better experience with one than another. And what this equianalgesic table means is that, for example, 30 milligrams of morphine, if we're looking at this second row here, is about the same amount as oxycodone 20 milligrams. The studies and the research that went into creating this equianalgesic dosing table were done in the mid-1960s, and that evidence that supported this were essentially in healthy individuals and looked at toxicity. So in terms of pain management and at what dose are we getting adverse effects in respiratory depression. And everything was compared to morphine. And that's essentially why everything comes back to morphine equivalents. And I'm sure you'll hear this in your own practice of like, okay, about how many morphine equivalents is this? And the guidelines speak to this too. So about 30 milligrams of morphine is equivalent to about 20 milligrams of oxy. Okay, so in clinical practice, what does that mean? Typically, we're thinking about oxycodone 10 milligrams. And so if you think about oxycodone 10 milligrams every 4 hours, for example, for acute pain, that's about equivalent to morphine 15 milligrams or hydrocodone 15, which would be, because hydrocodone doesn't come as a 15 milligram, we would probably decrease the dose to like a hydrocodone or a Norco 10 milligram. And then this hydromorphone about 4 milligrams would be equivalent. And so my takeaway point of this table is to use the equianalgesic dosing table for your patients. If they're already on an opioid, it is important to track from visit to visit how their usage is changing, and not based on how it is prescribed, but how the patient is taking it. And this is important because even small changes in morphine equivalents can impact tolerance, and eventually dependence over time. And so it is important to to keep track of morphine equivalents over time. And we'll talk about the follow-up visits even more. I could talk about opioids all day because that's what I do. So if you have further questions on opioid selection, happy to answer those at the end. But for the sake of time, I'm going to keep moving forward. So we want to start in terms of recommendation number 4, when we are initiating an opioid, we've selected which opioid for the patient based on patient-specific factors that can include their kidney function, concomitant disease states, the previous treatment, if they've tried an opioid before, if they've had side effects, the formulations that it comes in. A lot of our patients can't swallow tablets for one reason or another, and so we're thinking about which formulations come as a liquid. And then insurance coverage as well always impacts. And so we want to start with the lowest dose and make small incremental adjustments, carefully evaluating the benefits and the risk when considering any dosages, any dose increases. And as the dose increases, reevaluating, is the patient getting increased side effects? What are the risks to the patient? And are they still achieving benefit from this medication? So some of the things, and I wanted to break this down a little bit because across the board in these guidelines, multiple times they say when benefits outweigh risks. Well, what does that look like? And that is going to look different for each patient, right? But some of the benefits that the patient may be getting, right, is going to be in terms of function, their quality of life, sleep, and their psychosocial benefits. How are they interacting on a day-to-day basis? Are they able to work, go to the grocery store, do their laundry? These are things I'm asking patients in assessments. But the risks that we're really focusing on, and it comes down to safety, is are they having increased falls? Have they started a new medication that increases their risk of CNS depression since the last time you saw them? Do they have significant side effects now at this dose? Several of the side effects of opioids are not necessarily dose dependent and can present at any time, like constipation. Just because the dose is increased doesn't mean that the constipation may get worse. And so we're continuing to assess, are they having side effects from the medication? Do they have a new drug disease interaction? And by this, I mean, is an opioid now significantly going to impact options for treating their diagnosis? So for example, I'm just going to point out one example. So like pancreatitis, for example. I see this a lot, pancreatitis, acute pancreatitis pain, and absorption issues. And so we're kind of reassessing, is an opioid going to slow GI transit? Is this going to be beneficial to the patient? Are they at risk for necrotic bowel or bowel obstruction from an opioid medication? And maybe they have already had one of these, and it's time to consider a medication that's less constipating, like buprenorphine, for example. And so I think, and recommendation number 4, use low doses, slowly increase them, and continuing to reevaluate the benefits and the risks. I like this visual. This is a nice visual. It describes kind of this iterative process that I've been mentioning about pain management in terms of assessing the impact on function, sleep, quality of life. Number 2 here is describing optimizing non-pharmacologic treatment. Number 3, educating about the benefits, expectations of pain management treatments. My clinical pearl here, and I think the guidelines do a nice job of highlighting this, is that opioids don't treat every type of pain. And sometimes patients need to just hear that. Opioids are not effective for every type of pain. You really need to break down what is a pain generator, what is a pain etiology, and which medications, based on the mechanism of action, make sense for treating that pain. Opioids are as we're describing, may be appropriate for acute pain for a short duration of time. But as you increase dosing, if the pain is not improving, it may be that the opioid isn't helpful for the type of pain that they have. And it's okay to pause and reassess that. Number 4 is optimizing non-opioid therapy. 5, opioids for less than a week duration typically is what we start with. And then 6 is a follow-up to reassess that quality of life, sleep, daily functioning. And I think it's important to highlight the follow-up is so important. I think the previous guidelines in 2016 did not highlight the importance of in the frequency of follow-up and at what intervals that should be. And because opioids and courses of therapy change from week to week, and you can get tolerance to an opioid within a week, that it's important to continue to reassess the effectiveness of the therapy. Recommendation number 5. So for patients already receiving opioid therapy, clinicians should carefully weigh benefits and risks, again, and exercise care when changing opioid dosages. If benefits outweigh risk of continued opioid therapy, work closely with the patient, optimize the non-opioid therapies while continuing opioid therapy. So if you're acquiring a patient from a coworker who has left their practice or from another clinic, or the patient has moved and is new to your practice and they're already on opioid therapy, that it is always important to check back what non-pharmacologic and non-opioid medications has the patient tried? Have they been optimized? Are they at goal dosing for the type of pain that they have? And if not, that's okay to reassess those opportunities. And if benefits do not outweigh risks, making a plan for gradually tapering to a lower dose. And we'll talk about this in a little bit more detail. So unless there's indications of a life-threatening issue such as impending overdose, urgent signs of opioid-related adverse events like confusion, altered mental status, sedation, slurred speech, the opioid should not be discontinued abruptly. And that would cause acute withdrawal syndrome, and we should be preventing that. That is one of the situations in which patients will seek opioids or treatment through alternative routes. And so we need to support our patients in doing this safely with our support. And one of the things I wanted to highlight here, so the FDA, yes, identifies harm reported from sudden discontinuation of opioids. The previous guidelines did not provide as robust tapering guidance, which is, I think, an improvement in the new set of guidelines. And providing specific recommendations on tapering is important because every I'm going to say a taper plan is going to be unique to the patient. There's not one taper plan that can be universal for everyone. And it's important to highlight that because some patients may start on a taper that has worked for one of your patients in the past, like decreasing by 10 to 20% every 2 to 4 weeks. And then you get to a stall and maybe the patient's pain increase or they're having increased adverse effects or starting to feel opioid withdrawal adverse effects. It's okay to increase the dose again and then eventually decrease it in a slower mechanism. And it can take months. I think that's important to highlight. It can take weeks to months to even years for this. And you may get to a point where you're decreasing the dose to a certain amount, and then it may be important to consider transitioning to buprenorphine. Yeah, so these are also some points to highlight in determining whether, when, and how to taper opioids, providing advice to patients on what that means and how it's going to be a stepwise approach. And if they reach a point where they are feeling very uncomfortable, to reach back out to you to make a new plan. taper plans aren't a one and done. It's oftentimes implemented, and then there's a point at which you need to reset. This is an example of a few tapering resources that will be available to you. This is Dr. Lembeck. It has a nice video, and also the VA has wonderful opioid tapering, this wonderful opioid taper decision tool, and the CDC also has a pocket guide. And before I hand it over, I just wanted to highlight one of the important options for tapering, and that is not strictly if you're failing or having difficulty with a taper, then consider buprenorphine. Buprenorphine can be considered much earlier on. This is just an example schematic, but there's this is a list of multiple different publications on buprenorphine for analgesia. And I think that was, and I'll highlight this in a little while, but this was kind of a shortcoming of the guidelines in highlighting buprenorphine for opioid use disorder, but less so for analgesia. And now we have such robust literature supporting buprenorphine for pain, even as a first-line agent. And so we can dive into that in a little bit, but feel free to check out these pieces of literature to familiarize yourself with buprenorphine. I'm going to hand it over next to Eliza to continue conversations about deciding duration of initial opioid prescription and then conducting follow-up.
Great. Thank you so much, Jillian. Always learn a lot listening to you, so thank you for that. So let's say we've now decided that we are going to initiate some kind of opioid therapy, right? The risk-benefit calculation makes sense for this particular patient. So let's think about how we're going to decide the duration and how we're going to do our appropriate follow-up of the patients. Recommendation 6 sort of returns to that discussion about acute pain specifically. And it really focuses on the fact that clinicians should prescribe whatever the quantity of pills is that is expected for a given clinical scenario. This is, of course, really tricky to figure out because we just talked about how every patient is different and every plan needs to be individualized. So there is some nuance here. However, there are a lot of great tools out there, and one that is linked comes from MOPIN, and their website has a lot of guidance around expected duration of pain and number of opioids that you might need to prescribe after, for instance, various certain surgical procedures. So that can be a really helpful resource, but again, individualizing with your patient and having those frequent check-ins to see how they're doing. And then just to note that a lot of those resources that exist, including the ones on MOPIN website, don't account for folks who may have pre-existing opioid tolerance, right? So whether that is just patients who have been on chronic opioids for pain, or whether that is patients with opioid use disorder. So in those dependent patients, absolutely the quantity is going to need to be higher. So it's really important to take that into consideration. Otherwise, we very much risk under-treating folks who are already dependent and really not managing their pain appropriately or fairly. But good guidelines to look at links there. So again, we've talked endlessly. I think we've said risk-benefit analysis a lot of times. So let's talk a little bit more about the detail of how we're going to do those assessments. So first, with recommendation 7, this is really focused on the fact that we need to have ongoing periodic monitoring, and it gives some general idea about this 1 to 4 weeks within starting opioid therapy for a subacute or a chronic pain. However, there really isn't specific recommendation around the frequency based on your patient's various risk profiles, right? So the interval at which you want to follow up is going to be so different based on that individual patient. So difficult to give a blanket guideline here, and that really needs to be individualized based on that risk-benefit profile and what else is changing in that patient's health, right? As Jillian mentioned, people are evolving in their disease processes, they're getting medications added, removed, so just really important to be revisiting that frequently. There are, of course, many factors that can increase folks' risks of opioid therapy. And Jillian alluded to many of them, but just, a few to really consider kind of top would be, folks with already existing sleep disorders, any co-prescription of other, CNS sedating medications, and certainly anyone with a history of overdose, a history of adverse effects from opioid therapy, or a history or active substance use disorder. And you might also consider some additional monitoring in folks with liver disease, renal disease, or particularly in our elderly patients, right, who have oftentimes very long medication lists and a lot changing with their health, might monitor those folks a little bit more frequently as well. Recommendation 8 outlines the importance of implementing strategies to mitigate opioid-related risks, right? Once we've kind of done that risk assessment, what are the things that we can do to decrease risk? Some key examples, but there are endless examples, but a few that you really might want to consider are, first of all, some data gathering through reviewing the PDMP data, toxicology testing, taking a patient's history and finding out if they have severe mental health concerns or a history of substance use disorder or ongoing substance use disorder, and certainly connecting folks to resources as needed for those issues. We can always prescribe naloxone, and particularly important is actually educating your patient about the use of naloxone, right? I think it's so much out there in the ether at this point and everyone's heard of it, but a lot of people don't actually know how to use it. And particularly letting folks know that they're not really going to be using it on themselves, but they need to make sure that their family or whoever is in their home with them or who they interact with frequently are really the people that should have the naloxone. And just make sure they understand and that their loved ones have education around how to use that. I think also really important talking point around naloxone for patients when you're prescribing is that you're not prescribing it because you think they have an addiction necessarily, right? I think a lot of people equate naloxone with, oh my gosh, you think that I'm addicted, right? I think I hear that a lot. I'm guessing folks have heard that. So really, you can just say this always goes along with opioid therapy. It has nothing to do with dependence or addiction. Finally, really vital to just convey your risk assessment and plan with the patient. I think a lot of times patients don't have any idea exactly what we're worried about, and it can really help them to understand sort of their own risk profile. How do you understand that? And then give them a lot of clear education about the risks so that, again, they can participate in that shared decision making as well. A lot of states have various policies and recommendations. A lot of this stems back to the 2016 recommendations. Particularly, there are a lot of policies in different states around limits on the number of days that you can prescribe opioid therapy in the setting of acute pain. So here, this is in Michigan, and the limit for acute pain opioid supply is 7 days. If you happen to be listening to this webinar and you're in a different state, just be aware of your local state policies around this. And then a lot of states also have various sort of consent forms, conversation forms to have with patients. In Michigan, we have the Start Talking form, which probably many of you have used. And this really, it goes over, again, sort of that you've documented this risk-benefit discussion with the patient around the initiation of opioids. And I think, again, sort of how you present this to a patient is really important. I think a lot of patients feel like, oh, you're saying I'm going to get addicted or that I am addicted, and so you're making me sign off on this form. I think really I like to use it as like, this is a way for us to have a conversation, make sure that I've given you all the information I need to give you, and for us to have some back and forth and shared decision making about starting this medication. But I think this can be a nice tool for having that conversation. And I've noted is available also in Arabic and Spanish and probably other languages in the future. This is another just a set of pictorials that really reminds, I think, particularly patients. A lot of us, I think, know some of these facts, but a lot of patients aren't aware. So specifically, first of all, that we can review with people that opioid-related deaths occur commonly, and really they can occur in people using prescription opioids appropriately. Right? I think there's a lot of idea out there that only someone with an active opioid use disorder or an addiction is going to overdose, but that really people can overdose on their prescribed opioid medications. That the risk of addiction is real, and it doesn't mean that you have to come from a traumatic past or have mental health issues or have a prior substance use disorder. That really ongoing exposure to opioids is a significant risk for becoming addicted or developing an opioid use disorder, regardless of the person. And then also that combining opioids with various other medications, as we've talked about, CNS depressants, but also over-the-counter medications or alcohol can really increase risk, right? So, we know what we're prescribing, and we can certainly do our careful review of medications when we're giving opioid therapy, but really important that patients know, if they take cough medicine with codeine, right, they might get extra sleepy, or they might have more adverse effects if they're on opioid therapy. Similarly, if they use alcohol, there's a significant increased risk there as well. Recommendation 9 outlines kind of what I've already referred to multiple times, which is the PDMP data, right? So every state at this point has some kind of system where we can log in and see what controlled substance the patient has received, who it's come from. And in Michigan specifically, our system called MAPS, the Michigan Automated Prescription System, also includes some really helpful data that sort of risk stratifies folks based on what they might be co-prescribed. So it can be a nice quick view kind of a patient's risk profile, but also for us to assess if they're getting controlled substances from other providers when they've picked up, all of that kind of information. And this can really help us further risk stratify folks, particularly by noting their morphine equivalents that are calculated on there, their co-prescription of other controlled substances. And in particular, this recommendation doesn't really clarify what periodically means, right? They say review the patient's history of controlled substances. It doesn't really say how often we should be doing that. So this is really left to your clinical judgment. And for many of us, like I know at Michigan Medicine, our EHR stops us from prescribing without actually checking it. So we really just check it every single time. But that may not be the case. So if that is not the case in your EHR, you can really use clinical judgment, or your institution may have a policy around how frequently to review it, and the recommendations sort of leave that open-ended. Recommendation 10 encourages us to consider the risks and benefits of toxicology testing as part of our assessment. So, it doesn't say you must do toxicology testing, but as something to think about. And this kind of testing can provide really helpful clinical data to further assess risk by showing both prescribed and non-prescribed substances. And just really important thing to note is that a lot of the screening tests, which we see up here, there's sort of the screening toxicology and then confirmatory. A lot of the screening, there can be many false positives, many false negatives. So always important to interpret this in the clinical context and use your history really, and then this just as an additional piece of information. And if you really do have a question, you can always send off the confirmatory testing. But of note, that is notably much more expensive and obviously doesn't come back at the point of care in the moment. So has some downsides to it as well. And so toxicology testing can be really helpful and effective, but certainly if not administered and communicated to the patient in a really thoughtful way, it is a place that we can very much unintentionally harm our therapeutic relationship with patients. The Curbsiders podcast, which is shown here, has a really great set of tips around communication, such as explaining to the patient up front how you're going to use the results prior to testing and not kind of surprising them with a test. Using really neutral, non-stigmatizing language in your discussions, right? Just your urine was positive for XYZ, not your urine was dirty. And then in the setting of unexpected results, I think that's really a particularly important moment to stay cognizant of your language, such as using, an unexpected positive instead of dirty. And then again, remembering false positives are really not uncommon. So making sure the patient doesn't feel like you're accusing them of something that, showed positive and then actually really isn't in their system. And finally, toxicology testing is an area particularly vulnerable to all of our implicit biases. And as such, that can be a way in which we unintentionally perpetuate health inequities. So really would encourage everybody to assess your own toxicology testing practices, and that may be institutional guidelines, but really doing that always through the lens of implicit bias and equity. We know, for example, that if testing is only done sort of on a PRN basis, right, just sort of like when you think it might be indicated, we actually have good evidence that Black Americans will be tested at much higher rates than whites if we don't have sort of a clear blanket policy about how we do it. So just to be thoughtful about that. Recommendation 11 reminds us to use particularly heightened caution when we're prescribing opioid pain medication and benzodiazepines concurrently. or really any central nervous system depressants, right? Like gabapentinoids are another big one, sleep medications, antipsychotic medications. And again, just very high risk of adverse events in the setting of those co-prescriptions, and particularly as folks become more elderly, more frail, have more comorbidities. I forgot to say also, Z drugs are a big one in there that a lot of times patients will maybe forget to report or just don't think about as being another potential risk. Regarding benzodiazepines specifically, there are a lot of great tools out there for having conversations around benzodiazepine management and various toolkits. And one of them is linked here, but many exist out there to help you in those conversations. And if you do need to do tapering, guidance around how to do that. Recommendation 12, our last recommendation, really reminds us to offer treatment with any medications for opioid use disorder if they are indicated, right? So implicit in that is we have to be frequently assessing patients for the development of OUD. And I think we all know this is very complicated in the setting of a patient who is using prescribed opioid therapy to really assess whether they have developed an opioid use disorder, not just tolerance or dependence on the medication. And do remember that, OUD can develop in patients who are, appropriately prescribed opioid therapy. Maybe they don't have a lot of other risk factors that would lead you to think about a substance use disorder, really can still develop. So finding a way to frequently assess that in a non-judgmental way with your patients. And really important, which is called out here, is that, if you do determine someone has an opioid use disorder and are thinking about treatment for them, detoxification alone without adding other medications for opioid use disorder is very much not recommended for opioid use because it really increases the risks for resuming drug use, overdose, and death. And there's actually a brand new study that shows that detoxification alone causes higher risk for overdose than no treatment at all. So folks really need an FDA-approved medication for the treatment of opioid use disorder if that is, if you do determine that they have an OUD. This is just another helpful graphic that outlines a lot of the key steps that we've been discussing. So for the sake of time, I'm not going to go through it in detail, but again, you'll be able to have that later in your resource. And then many, many resources out there around medications for opioid use disorder. This particular linked one here is from the National Academies of Sciences, Engineering, and Medicine. Again, just reinforcing that these are gold standard treatments that should be offered to everybody with opioid use disorder. Another nice pictorial that comes from NIDA, and this is really just, they have a ton of great resources that can be really helpful for if you've determined that your patient does have OUD. And this image just reminds us of all the different types of medications available, right? So there are the three sort of chronic long-term treatments, methadone, naltrexone, or Vivitrol, and buprenorphine, sort of as our ongoing therapy. But then additionally, there are many medications to help treat opioid withdrawal symptoms. And then, of course, as we've already talked about, overdose reversal medications. The one we're most familiar with, of course, is naloxone and Narcan. Nalmefene is also another newer one on the market as well. So these are all things that we can offer to our patients if we do determine that they have OUD. Previously, to prescribe buprenorphine, you had to go through, a lot of hoops. You needed to do an additional 8-hour training if you were a physician, go through a long application process to get an X waiver to prescribe buprenorphine for opioid use disorder. At this point now, there is no waiver, and if you have not already done this, it takes just about 5 minutes to go to the SAMHSA website. You can apply to be able to prescribe this as long as you have a controlled substance license. There's no extra training required if you're treating 30 patients or fewer. So much lower barrier now for all of us to be able to prescribe that. And these are just some more resources to support treating people with medications for opioid use disorder in your clinical setting. Lots of people are out there and happy to help, and Jillian and I and Eve are all people who would be happy to help. These are other resources. Particularly, there are free trainings and sort of at the elbow on-demand support from Michigan Opioid Collaborative and Open. And that can, really, we hope that makes it easier to embark on caring for patients with opioid use disorder if it's something new for you, or if you're already well-versed in treating, but you're struggling with a particular situation. We're happy to help. And really, these patients with OUD are already in our practices, so this is just our chance to offer evidence-based treatments to help. Another great pictorial, this comes from Wayne State University, and I love this. It is dense, but sort of goes through the 3 FDA-approved sort of long-term chronic medications to treat opioid use disorder. Buprenorphine and methadone being both agonists at that mu opioid receptor. Buprenorphine as a partial agonist, and then naltrexone, which is approved for opioid use disorder when it's in the long-acting injectable form, also known as Vivitrol. And this kind of goes through sort of, this can be helpful for patients, for families, and for clinicians about what will that medication do. How do you get started on it, which can be a little bit tricky. How do you get it? How often do you have to come for it? And then just, really important to note, this slide does mention counseling as part of the picture. There's actually excellent evidence now in a lot of studies that show that, counseling can be a helpful thing, but is absolutely not required. And actually, medications for opioid use disorder all on their own are efficacious in treating OUD. So patients do not need to engage in that if they are not ready or don't want to. Okay, so now that we've worked our way through the 12 recommendations, I'm going to give the floor back to Jillian to review a few key differences from the 2016 recommendations and also describe some critiques and possible improvements. Jillian?
Great. Thank you, Eliza. So what is different between the 2016 CDC guidelines and the new guidelines? And I want to dive into that a little bit more. And here are some of the critiques and a little bit of history behind the ones listed here. So Michigan Medicine, similarly to many health systems and organizations across the state of Michigan and across the country, had an opportunity during the open forum to provide feedback on the first version of the guidelines when it became available. And the CDC took that information into consideration before publishing the final versions of the recommendations. And so, for example, at one institution, we had 3 rounds of like an open forum going through each of the 12 recommendations to provide feedback on the recommendations, but then overall generally. And this was just feedback and critiques just from one group. And I think it will be interesting to hear feedback as more and more individuals start using the new guidelines. And some of the critiques that were not necessarily unique to Michigan Medicine, but some of the ones that we also were consistent with public opinion included that when opioids are needed for acute pain, prescribe no greater quantity than needed for the expected duration of pain, severe enough to require opioids. Likely, this tends to be 4 to 7 days or less. There's a lot more literature on specific surgeries and the unique amount of opioid tablets that should be prescribed for different types of surgeries. So perioperatively, there's a lot more available now to support quantities and also duration of therapy. And so I think this is a nice kind of reminder for all of you to consider in your patient with acute pain, when does that typically resolve? And taking that into account when you're prescribing the opioid. Buprenorphine was a major topic of discussion in terms of the guidelines, and I think there will continue to be opportunity to discuss this more. Buprenorphine should be considered first line for subacute and chronic pain. It has a lower risk of tolerance, lower adverse effects, works on multiple opioid receptors, including kappa and delta, and there is more literature to support its benefit for neuropathic pain, in addition to not contributing as much to opioid-induced hyperalgesia like our full agonist opioids. And so I think some critique is that we could kind of provide more robust guidance around using buprenorphine, not just for opioid use disorder, but as a first-line treatment for pain and when that is appropriate. Now, Eliza mentioned filing that notice of intent. It's a quick process, and that's needed to prescribe buprenorphine for opioid use disorder. But there are no special requirements outside of having a controlled substance license to prescribe buprenorphine for pain. Any provider with a controlled substance and a DEA can prescribe buprenorphine for pain. High-risk co-prescription should be named. The guidelines don't dive into which specific medications prescribed with an opioid come with an increased risk. And so this includes benzodiazepines, or Z drugs, gabapentin, and wanted to point that out. And then a periodic review should occur after 1 week of treatment. It expanded on the acute pain guidance and the subacute pain guidance, including more information about how non-opioid therapies are at least as effective as opioid therapies for certain conditions, which I think is really helpful for providers. And the expansion on the subacute pain guidance, so really honing in on what subacute pain is and evaluating patients, confirming diagnoses, working with patients to establish their goals, recognizing the education that needs to take place before an opioid is started, and then considering how that opioid therapy would be discontinued if and when that time comes. And then to wrap up this section, so initial and ongoing opioid therapy, it does really delineate between identifying patients who should be considered for an opioid for the first time for that course of treatment, and also differing patients who have already been on an opioid and how to help manage their ongoing pain, which is new and very much appreciated. And then in terms of opioid dosage guidance, it really honed in on the suggestion for lower starting doses, morphine and milligram equivalent for commonly prescribed opioids. We're kind of referring back to that equianalgesic dosing table I talked about earlier, and then the approach to dosage increases and emphasizing safe and effective pain treatment that is individualized and focuses on is the pain responsive to an opioid, or would it be more appropriately treated with a different analgesic medication? And so I'm going to hand it back to Eliza to continue our conversation about some disparities in treatment of pain.
Fantastic. Thanks again, Jillian. Back to me once more before you will round us out. So another piece that is different about these guidelines versus the 2016 are that there really is a focus on, an emphasis on acknowledging that there's been a long history of health disparities in the treatment of pain, acute and chronic, over the course of our history. So there's, a big urge for us to give very consistent attention to the existing health inequities as we move toward implementation in both the policy and the practice arenas. There is a huge body of evidence, and these are just 4 example articles, but at this point, really seeing that across all medical specialties, there are pervasive racial and ethnic health disparities in pain management, and I don't think that surprises any of us at this point. But specifically, we do see that Black Americans tend to be undertreated in scenarios of both acute and chronic pain relative to other racial and ethnic groups. There are also racial disparities in monitoring patterns for opioid misuse during the course of pain treatment. So as we implement the new guidelines into our practices and our institutional policies, just really important to have an equity lens at the forefront of our efforts all the way through. Similar to disparities in pain management, there are also a lot of disparities in overdose deaths. The graph on the right illustrates this increase, this disparate increase in the opioid overdose death rate among Black men in the U.S., showing that it tripled between 2015 and 2020. And in fact, 2020 was the first year in the U.S. in which we saw more overdose deaths among Black Americans than white Americans. Michigan, down there on the left, really mirrors this national pattern. So we see that the death rate among Black Michiganders is actually more than double that of white Michiganders, and much higher than other groups as well. So the reasons for these patterns are, of course, very complex and involve a mix of community factors, the drug supply, community supports, stigma, and of course, history of historical racist structures in society. So lots of work is ongoing to better understand this and get clarity, but there will be a lot of work to be done for us to pay attention to. And so certainly, while the reasons for high overdoses are, really complex, one contributor certainly is that the majority of folks with substance use disorder don't actually receive any treatment. And we see over here on the left, there are only just a few little blue people down there who actually received treatment. So we have a lot of work to do in expanding access to treatment, and specifically for opioid use disorder. We do have these highly effective life-saving treatments at our fingertips. Yet the great majority of people with opioid use disorder do not receive that kind of treatment. So there's a really important opportunity for us to expand access across the healthcare system, but particularly for those of you who are also primary care providers like me, a lot of opportunity for us to do this in our setting. And I think it is very much in our wheelhouse as primary care providers, and I think that we are fantastically positioned to do it. A lot of studies have now shown that again, opioid use disorder is a chronic illness, and it's really effectively treated in the primary care setting. So for any PCPs in the audience today like me, certainly you do not need to wait for an addiction specialist to, provide this very life-changing and life-saving buprenorphine treatment. It's in our wheelhouse, and in fact is more effective at saving lives than any other medication we can really provide in the primary care setting. This is just another way of looking at the great need of buprenorphine prescribing. So the darker spots on the map are places with a lot of need and low capacity. For those of us here in Michigan, we see that there are absolutely a lot of dark spots within Michigan. Not as much sort of where Jillian, Eve, and I are in Washtenaw County, but a bit further north. A lot of needs still there, and then across the country. And this is really, it's a map that we are capable of improving as providers who are able to prescribe buprenorphine. Not surprisingly either, but unfortunately the disparities that we talked about in pain management and opioid overdose also show up in medications for opioid use disorder management. And there's a recent New England Journal of Medicine study that looked at Medicare claims data and really saw that there was a dramatic differential in receipt of medications for opioid use disorder among Black Americans who had had an overdose versus white Americans and any other group. So clearly, systems changes are really going to be vital, but we can each act sort of at our own individual level to address our implicit biases, to begin prescribing, and that way we can make change today without waiting for systems to make the change for us. This wonderful but sort of complicated image just sort of maps out a theoretic model of various community and healthcare factors that can impact opioid outcomes. We really look, certainly on the left, there's the individual, right? That person has all of their own factors themselves, but there's really a lot about the community environment that can help either prevent overdose or allow it to happen. So, in a community, for instance, what's the access to opioids? Are there services to link that person? If there are, even if they have individual risk factors for overdose, we're going to be able to prevent that overdose. And, do we have, is our healthcare environment ready and set up? Do we have naloxone available everywhere in the community? There are a lot of great organizations, around us, for instance, the Red Project in Grand Rapids, Unified here in Washtenaw County, Root, which is an opioid overdose response team here in Washtenaw County. These are all examples of some of those community factors that can sort of put up a wall where if someone's heading toward an overdose, there's a way to stop that overdose from happening. And then sort of, again, within the healthcare environment, primary care setting, but also in the emergency setting, these are other places where we can prevent an overdose from happening. And if we someone gets through all of those layers and our community and our healthcare system are not well enough equipped, then that's where we see, adverse events and overdose and deaths as well. So again, sort of regardless of somebody's individual factors, our communities and our healthcare system can very much step up and help. So just want us all to feel empowered to be able to help prevent death in our communities using the evidence-based tools that we have. So finally, I'm going to pass back to Eve to share some concluding thoughts and resources before we move on to questions. Eve?
Thank you so much, Eliza. So this can feel a little insurmountable, right? These are big challenges that a hospital or a clinic cannot fix in isolation. Rather, we need to address these challenges as communities and as a country, and we need to take a coordinated public health approach, whether it's equitable pain management and just pain management in general, or it is tackling directly the opioid epidemic and the crisis of individuals with opiate use disorder who are not being offered appropriate evidence-based care. So it's the ED, it's the hospital, it's first responders and law enforcement, it's local health departments, it's SUD providers, behavioral health providers, primary care providers, I think are really critical to all of these efforts. And then of course, community members and community organizers, we all have a role to play. The CDC guidelines are one strategy among many. And if we can apply an evidence-based approach to pain, I think we have the opportunity to do a lot of good. We have rebranded our Safer Opioid Prescribing Toolkit to a Safer Prescribing Toolkit because of course, opioids are not the only challenge, the only controlled substance that can cause difficulties for our patients. Coming soon, you're going to see a whole section on benzodiazepines, and we are working on a section on stimulants as well as health equity that will be hopefully coming this summer. We are not alone at the Injury Prevention Center in doing work. We're just a tiny part of the community of advocates and providers working around harm reduction. These are the images of a few organizations. If you don't see your organization represented here, please tell us about yourself in the chat, even if it's just the name. We would really like to include you in our resource list. Without further ado, let us go to some questions. Thank you so much for joining us today. I think we may have several questions, and so we're going to get to as many as we can. My apologies in advance if we're not able to get to you. Please remember that you will be getting an email from our team. Fill out the evaluation. Let us know how we did with this topic, if there were some points that you wish that we had addressed, and if there are topics that you would like more information on, and topics that you would like us to address in the future. So with that, I'm going to invite Eliza and Jillian to turn on their cameras. And I believe that my colleagues Taylor and Jill are working on getting us the questions. So let me go to them. Okay, so Taylor has given me the first question. In the next iteration of prescribing guidelines, what do you hope will be given more attention? Eliza or Jillian?
I think Jillian outlined many points that I would just echo already. And particularly for me, as an addiction doctor as well, I of course think about a lot of folks who are sort of in that OUD category. And what I would love is actually more recommendations focused on folks who sort of have chronic pain, but also opioid use disorder. I do think that we have sort of swung to not treating folks with OUD very well with their pain because we feel nervous, obviously, because we feel that we've historically caused harm to people and gotten people addicted. And so I think that we do undertreat both acute and chronic pain in patients with opioid use disorder. So I'd love to see a section sort of focusing on that. And as Jillian mentioned, using buprenorphine more as a frontline agent for managing chronic pain instead of other opioid therapies. I would add that, and I don't know what else, Jillian, you might add.
I'll just add to, I think one of the shortcomings is calling out sickle cell and cancer pain management separately, when a lot of the principles of this guideline really does hold true for those populations. Of course, there are caveats, but I think partnering with some of these additional stakeholders and specialty groups, in addition to the ones that have already been partnered with, to really hone in on guidelines that can be applied to all the populations.
So the next question is, what do you think reduces clinicians ensuring I'm not sure that I understand this question, but I think it has to do with how to assess risk within a week of writing a prescription. So if you write a prescription, what are you doing within that week vis-a-vis addressing risk benefit with your patient?
Yeah, Jillian, you probably have things to add, but I think, coming from the primary care standpoint and in a health system that is very overloaded, getting appointment slots is probably a key. And I'm guessing that that's happening in a lot of particularly primary care settings. Many of us are booked out months. So being able to make a follow-up appointment in a week is a really tall order. So I think there's absolutely a systems challenge there. And I think, there are creative ways to, perhaps use a highly trained nurse or use a pharmacist. I think, if you have access to a pharmacist, someone like Jillian, calling to do a check-in with someone is a phenomenal way to sort of extend that care and use our teams to help us. But I think that is, at least in the primary care setting, probably our number one barrier.
I'd add on too, I think with limited resources, one of the ways I've seen clinics implement sort of like a checklist is kind of having, I guess, in one electronic health record, you can create smart text or smart phrases to incorporate into your progress notes or reminders that include a checklist of things that may include what specifically their goal is, how you want to reassess their pain, like what specific function are they working on, and then the parameters around refill quantities. And so this can also be a helpful reminder to other clinic staff. And we've incorporated a similar checklist for like refills of controlled substances in different clinics. So I think expansion, utilizing some of these tools if we don't have personnel to do the check-ins, so that whoever's receiving the call can have like, oh, this is consistent for individuals who are receiving opioid therapy.
Yeah, I will add that there are some really nice resources, particularly for post-surgical patients at MOpen. They give kind of general ranges of dates. So, for example, someone who's had their gallbladder surgery, how many dates does an average patient need? It doesn't address the person who is on chronic opioids and who needs a more nuanced approach, but someone who's opioid naive and just coming in for a surgery, they did a lot of research finding that we were prescribing 10 days of meds and people were taking 2 or 3. And so making sure that we don't have those meds kind of sitting in someone's medicine cabinet, potentially posing a danger, for example, to the young folk in the household. So one more question, is the Safer Prescribing Toolkit you mentioned just for Michigan-based providers? No, we do have a Michigan-specific section in the toolkit related to our local policies and laws. However, the majority of the toolkit is actually generally applicable to anybody who is managing patients who are experiencing pain. And so lots of really great national resources, particularly some wonderful ones from the VA. We think of the VA as, oh, well, it's only for veterans, but in actuality, a lot of the lessons for caring for veterans are lessons for caring for all of us, right? There are a lot of people who are not veterans who have experienced trauma, who have injuries that are causing them chronic pain. And so I do encourage everybody to look at the VA resources. I think they're particularly terrific. There are also some really nice videos that you can watch for how to approach difficult conversations that I think are really apropos. Let me see, there's another question. What proportion of people living with asthma cannot safely use buprenorphine? Given there is an increase in asthma cases, perhaps due to pollution, is there an increasing issue for avoiding the stronger use of opioids? So I think this person is talking about the respiratory depression of opioids in patients with pulmonary disease.
I can weigh in a little bit on this. Thank you for that question. I think that's really unique, and I don't know the current literature on buprenorphine specifically in patients with asthma, but there is literature out there on opioid use, and including buprenorphine in patients with COPD. And we do know that has a decreased risk for respiratory depression, even at very high doses. And so I'm sorry I don't have more specifics for you, but if the patient would be appropriate for an opioid for acute pain, I would steer towards buprenorphine first in that patient, depending right like on their asthma history. And Eliza, maybe you can weigh into that more, like their frequency of exacerbations, etc., and preferring buprenorphine before an alternative opioid, because they are at increased risk for opioid-related adverse events.
And I'll just second, yeah, exactly what Jillian said, and great question, because that certainly is right, air pollution is going to be an evolving issue. And I think, for anybody who isn't aware, buprenorphine does have this beautiful, we didn't talk about the pharmacology, but a beautiful sealing effect on it, right? And that sealing effect really means that people do not develop respiratory suppression. So in buprenorphine therapy alone, when it's not combined with any other CNS sedatives, we just really do not see any adverse effects with respect to respiratory suppression. So I think I would absolutely, anybody with severe, sleep apnea, COPD, or severe asthma, I would absolutely feel much safer using buprenorphine. And I'm not aware of any particular contraindication, and I have never seen someone who cannot be on buprenorphine due to their respiratory status.
Yeah, I will certainly echo that. All of the literature that I've reviewed suggests that buprenorphine is actually a lot safer in patients with any type of chronic respiratory condition. I am going to take a quick look and see if there are any more questions. It looks like those are the questions that we have for today. Again, I want to extend my thanks to everybody who stuck with us. I know that an hour and a half is a lot, and there's a ton of information that was presented today. Thank you, Jillian. Thank you, Eliza. So a lot to digest. I think I've said this now 2 or 3 times already, but we will be sharing the slides. This session has been recorded, and it will be on our website, and there will be a Google document, I should say, with the resources that we shared today. So again, thank you so much. If you find that you have a question after the fact, please don't hesitate to reach out to us at the IPC or put it as part of your free text in your evaluation, and we'll do our very best to get back to you. Without further ado, it looks like a sunny day, so enjoy, and thank you again. Take care.